Hi everyone, and welcome to this webinar. And I'm going to jump straight in and talk to you about precision medicine in type 2 diabetes, which, as Chioma mentioned, has become a bit of a side gig for me. Now, let's jump right in and define what we mean by precision. And you may not have seen the consensus statement that some of us were involved in publishing last year in Nature Medicine. It's a long read, but worth it. And basically, as you might expect, precision medicine emphasizes tailoring of diagnostics or therapeutics to subgroups of populations sharing similar characteristics. And sometimes precision medicine and personalized medicine are used interchangeably. So we've defined precision medicine. What does type 2 diabetes mean? And this is a little bit of a flippant question because I want to share with you some people that I recently saw in my type 2 diabetes clinic. The first one is Yang Mi, who's of Chinese heritage. She's had diabetes since she was 25. She has a BMI of 22, and you can see the HbA1c there is not quite at target. So she's lean, but has type 2. And then Jonas, who was from East Africa, and he'd presented with this sort of ketosis-prone type 2 diabetes phenotype, slightly overweight with a BMI of 26 and in DKA at diagnosis, but now off all treatment. And I'm seeing more people like Kirti. Kirti's young, but she has type 2 diabetes. And as Chioma mentioned, this is a focus for me in my Wellcome research. She's living with obesity and she has suboptimal glucose control as well, and already has evidence of complications. And then we've got Mark, and Mark is really the sort of person that I learned about when I was at medical school. He's a bit older, he has a BMI of 35, responding reasonably well to GLP-1. Now, how is it that all of these people are labeled with type 2 diabetes? And actually, we don't call them all type 2 diabetes. We prefix them with things that qualify. So Yang Mi's got lean type 2. Jonas is ketosis prone type 2. Kirti is early onset type 2. And then Mark, I like to say, is sort of garden variety type 2, which is what we all learnt about. So clearly, type 2 diabetes is a very broad label that encompasses a lot of different subphenotypes. And arguably, we should not be treating Yang Mi, Jonas, Kirti, and Mark in the same way. So what do these specific phenotypes tell us? Well, they tell us three things. One is that the etiopathogenesis of type 2 diabetes is heterogeneous across and within ancestries. It's not the case that everybody of Chinese or Indian or African heritage is going to present like the vignettes I just showed you, but those subphenotypes tend to occur more frequently in other ancestry groups. It also tells us that the lifestyle or the environmental component of risk is likely to be unmasking differential genetic contributors. How is it that Yang Mi and Kirti in the previous slide both have type 2 diabetes, but one has a BMI of 22 and the other has a BMI of 27? Clearly, there must be underlying genetic contributors. But it also tells us a third thing, and that is that, as I believe, our guidelines are currently inadequate because they tell us pretty much that one size fits all. And I can't tell you the number of people I've seen like Yang Mi who have lean type 2. And I'm not going to go into it in this talk, but let's assume we've excluded type 1 diabetes. Let's assume that we've excluded monogenic diabetes and we're left with lean type 2. And lots of healthcare professionals will tell Yang Mi that she needs to lose weight. And I think that's the wrong advice for somebody that has lean type 2 diabetes, because intrinsically they must have a problem producing insulin. So what do we do when we see a new presentation of hyperglycemia? Well, I'm not saying we're particularly good at it, but we're definitely getting better at identifying monogenic diabetes in that ocean of type 2 diabetes. And there might be some red flags for type 1 diabetes as well, or other types, for example, pancreatic type 3C. And everyone else just gets lumped into this group labeled with type 2 diabetes. It's almost a diagnosis of exclusion, or rather, more often, the default diagnosis. And I still think it's incredible that despite all of the advances we've made, we actually don't have a test to conclusively tell someone that they have type 2. We have tests to rule in type 1 and monogenic, but we don't have anything to say you've got type 2 diabetes. And so we bung everyone into this bucket of type 2 diabetes, but as you've seen from those case vignettes, it's very heterogeneous. And we can start to segregate people in this group on the basis of certain clinical features, as I showed you in the previous vignettes. For example, age of onset, presence or absence of DKA, or the BMI. Is it lean? Is it overweight? Is it obese? But what we see is considerable clinical variability in the way people present, how they respond to pharmacotherapy, and the risk of progression to complications. So the question really arises, can we be more refined in our approach? Now, broadly speaking, the answer is yes. There are many, many groups working on this, including my own. And we can be reactive to classification. So as I've shown you, we can look at the clinical phenotype and say, well, that person's obese, that person's lean, that person needs insulin, that person doesn't need insulin, that person was in DKA, that person wasn't. This is a very reactive classification-based system. Or, as many people are trying to do now, we can really dig a bit deeper and look at the etiopathogenesis, and that might be incorporating genetic markers, or it might be combining multiple biomarkers to really understand the underlying pathophysiology. And we're starting to see that with some of the approaches that can identify people with lipodystrophic type phenotypes versus beta cell dominant type phenotypes. And if you're interested, because we don't have time in today's presentation, but if you're interested, please have a look at our systematic review of all of the different approaches to classification. And what you can see is that what's predominating these days in the literature are computational approaches towards classification. And that's shown in the cartoon on the right-hand side. So you can input different variables, for example, the BMI, the HOMA, the HbA1c, or even more complex omics data. And you can undertake different machine learning methodologies to subtype type 2 diabetes. So what would state-of-the-art precision medicine look like? Well, I've taken, I hope Professor O'Reilly doesn't mind, but I've imagined that I'm sitting in clinic with him and he calls in his next patient, and his next patient is me, with newly diagnosed with diabetes. So how could we advance on what's going on at the moment? Well, he might take a finger prick and undertake some precision blood tests in inverted commas. And he might say to me, well, Shivani, you've got type 2 diabetes subtype 623.4b, and you need the following treatment combination. And I've measured your serum rhubarb level, and I advise starting an ACE inhibitor because you're at risk of renal failure in the future, and we need to protect you from that, etc., etc. So this might be, I'm not saying this is my vision of what precision medicine would look like, but this is what we're effectively heading towards, a more nuanced diagnosis and a more nuanced treatment. So how much of a reality is this today? Well, let's just run through the steps that we need to be able to achieve something like this scenario that I just mentioned. First of all, we need to precisely subclassify type 2 diabetes. We then need that to be a useful subclassification. There's no point me saying, oh, yes, you have a high chromogranin A and you have a low chromogranin A. What does that actually mean? Does it associate with a difference in complications? So we need to have a useful classification. Then we need to leverage those classification differences to select a more targeted treatment and a precise prognostication. And then we need to show that that prognostication improves outcomes. And finally, and this is the most important thing, we need to make this clinically usable, because we can come up with the most precise subclassification and manageable. If it's not being used at the interface by, for example, GPs who see the majority of people with type 2, then it's not going to make a difference. So where are we with evidence that stratification works? Well, again, just a précis given the short time today, but the field is moving very, very quickly. On the left-hand side here, you can see the first ever randomized controlled trial of a precision medicine approach that stratified patients according to their BMI in the top panel and their eGFR in the bottom panel. And it shows marked differences in the glycemic response to sitagliptin on the left and favors pioglitazone on the top right or canagliflozin on the bottom right. Don't spend too much time looking at this. Just note that there are significant differences in drug treatment response on the basis of simple routine biomarkers. And here's a very famous graph taken from a study by Emma Alkvist in 2018, which shows the first clustering study. And what it shows is that if you cluster on the basis of simple routine features at baseline, you progress differently. And this graph shows the progression to end-stage renal failure. And the green line, which obviously progresses quite rapidly, is the SIRD, or the severe insulin resistant group. So even at diagnosis, you can predict who's going to develop these complications. Now, this clustering approach has really taken hold. This is in our systematic review. It shows a huge number of studies, now all looking at the clustering methodologies. I'm not going to go through it, but I will say that it does have limitations. These clusterings assignments can change with time. And really, again, as it boils down to, will this be used and can it be applied in all ancestries? So just in the last minute or so, I think where we're at in this pathway of precision medicine is that we've got to an approach where we can subclassify type 2 diabetes in a more refined way, but we're yet to be able to leverage that treatment, stratification using more targeted treatment. But this, just to whet your appetite, came out just last week in Diabetologia from the Exeter group. Again, a very complicated graph, but all I want to show you is that the brown represents the response to an SGLT2 inhibitor, so how much your HbA1c reduces, and the darker the color, the greater the HbA1c reduction. And the blue is the same for a GLP-1. And the key point here is that these are all not at the same level. And you can see that very simple things like age, HbA1c, eGFR, and even gender will influence the degree to which you achieve glycemic reduction on these agents. Now, of course, 4 out of 5 people living with type 2 are in low and middle income countries. So we need to make sure that whatever we do in this space has the ability to reach all of the people with equity and equality. So that was a run through, very fast run through. What have we covered? Hopefully I've shown you that the type 2 diabetes label inadequately covers disease heterogeneity, and a more refined classification based on clinical features is needed. And this is especially true across diverse ancestries who are underrepresented in most T2D studies. There's lots of different approaches to stratification. Clustering has definitely taken hold. It's associated with mortality, CVD, and renal outcomes. And there's some way to go to make clinically usable tools from these stratification methodologies and to also prove that they are superior and cost effective versus standard care. And actually, maybe someone will ask me this, is it worth delivering this? Maybe we should just put everyone on a GLP-1 agonist. I'll wait for that question. And so I just want to finish with this quote from William Osler, who said in 1892 that it is more important to know what kind of a patient the disease has than to know what kind of a disease the patient has. And I think he was quite prescient about the concept of precision medicine in making that quote. Thank you very much. Back to you, Chioma.